So kia ora koutou. It's very lovely to be here. Ko waio, no tamaki makaurau, no putararu ahau, ko otu tahi tōku kāinga e nei, ko Kaaren tōku ingoa. And I've got a real interest in how results happen and what actually happens, but in that kind of someone goes to a healthcare worker and their mental health gets better, but what actually happens in that interaction. And so I'll be exploring that today. And the reasons why I think this is a really important thing is that there's a huge amount of interest globally and in New Zealand saying we know that we can't solve mental health problems exclusively with psychiatrists and psychologists. They're very expensive to train, and often there are simpler solutions that can be delivered by frontline health workers. This is really evident in New Zealand. This year, in a rare act of benevolence, the National Party announced new money for mental health peer support workers in emergency departments. And it's an area that has been really growing a lot in New Zealand in the last 4 or 5 years, where people are really interested in saying, what is it that happens when people can improve their psychosocial well-being, and can that be done by unregulated practitioners contribute? And if so, how does it work? So there's a growing call for it because we know that mental health problems are a really major cause of disability. They're the largest cause of years lived with disability globally, and they're also increasing, and we're not really quite sure why, but nearly about five or six studies in New Zealand in the last couple of years have shown significant increases in mental health problems. So we can't address it all with psychiatrists and psychologists, and there might be some sort of simpler solutions within communities. There's also some really good evidence where we know that 80% of health problems happen outside of the health system. So things like quality of your housing, the consistency of your parenting, your access to exercise and green spaces and fresh air and all those things. And so the really interesting thing in this study was, what do health workers do that address social determinants of health? And what are their micro innovations? So these are two questions. One is, what are the strategies that community health workers use to address social dimensions of health? And why use data from Aotearoa and India? These are both the two countries that I strongly belong to. And I have found in my research in both places that there's a lot of intersection. So I'm presenting data that were from two different studies from two different settings. In Aotearoa, New Zealand, it was a study I've been doing with Annabelle Ahuriri Driscoll, and it was looking at how do child health service providers improve equitable health outcomes. So we did a case study of 3 services. You may know these ones. They're all 3 of them in Ōtautahi, Te Pua Waitanga, Pura Pura Whetū, and Early Start. And in India, it was looking at one organisation, Burans, who are a community mental health provider. So that was the setting. The contexts are quite different. We're all fairly familiar with the lovely flat Christchurch with the lovely hills that we've got west of us and the Port Hills. And this town, Dehradun, where the study was set, is also a flat valley with steep hills. It's right at the base of the Himalayas. So it's got a few topographical similarities. It also gets an inversion layer in winter. But that's probably about where the similarities finish. What do kaimahi or frontline health workers do in Christchurch? Quite a range of roles. Some are called kaiawhina, some are called whānau workers, some are called kaimahi. But they're the people who go into homes, meet up with people in the community, and it's a mix of regulated, which might be like people with a social work training, as well as unregulated providers who maybe have their own lived experience, or they maybe came from another background. In India, in Dehradun, this organisation focuses on mental health care, and so they identify people with mental health problems. They provide active listening and problem solving, which I guess is components of what we would call counselling. And they also help people get to biomedical care when they need it. So this was a qualitative study, 16 interviews with a range of people in services in Aotearoa and 46 interviews with health workers in Dehradun. We were trying to find out what do you see as social determinants of health? What are the biggest factors influencing health outcomes? How do you interact with clients? What do you do when you meet? What do you actually do? And what changed? What were the outcomes that you saw? What were some of the barriers? It was a simple thematic analysis with myself and another person in both the studies. So I found 3 key findings, and I want to take a little bit of time on them because they're really, really strongly connected in both the places. The first one is that the frontline health workers had a really strong understanding of the local context. When I went out with the Purapura Whetū workers, we were mostly working in East Christchurch. They all lived in that area. They had mostly grown up in that area, and they understood what was happening for a family when we walked into the house. And this was an example of a commentary that I recorded with one of our health workers in India, and we were on our way walking through some narrow little lanes in an urban area, and I said, well, tell me about Deepak, who we're going to visit. And, the health worker's sort of walking on and says, well, he's 21 years old, he's grown up in primary school, his dad was working in this, and then his uncle died, and then, and she just reeled the whole thing off. And I just was like, she had no notes, she had no file in her hand, she just knew this guy's story really, really well. And she said, well, because his dad went to prison in his mid-teens, it was really rough on him. He was then the main breadwinner for the family. He does any kind of daily labouring work, but he really has a very poor self-image. And, so it's going through and exploring things. And this is some of an example of one of the groups that Deepak joined, which made a really big difference. So that understanding of the context and also knowing the families really well is a really core ability to respond to social needs. The second thing was the relationships were really, really tight, and there's a really high level of rapport. And when I talk about this, it just seems so obvious, but it's something that funders do not fund most providers to have a long-lasting relationship over many months or years, and that is really something that we know transforms outcomes for families. And so this was a mother in Purapura Whetū, and she was talking about the kaiawhina who she had worked with, and she said, they tell us about their family experiences. Like, you kind of get the feeling like they're family mothers and sisters and grandparents, and it's just real. Like, it's a really good way to break through the walls. And so just the value that kaiawhina offer because of their own ability to form relationships, and that I've done some other studies looking at how that works, and it's really important to build a sense of trust and connection. And lots of the people I've talked to have said it's only after I visited for about 7 or 8 months that she told me about her child being abused, or that, and it's that level of trust is what you can only get with a good relationship. And so that was a really core thing to be able to respond to social determinants. Another example was people, frontline workers, talking about, well, this is how it was for me when I was in a similar situation for you. And a young guy who I talked with, who was out in Waimari Road, out behind, I don't know, he said, well, the reason that I really like meeting up with the young man who was his support worker is he's been through the same stuff as me, and I'll ask him, how did you manage to get through? How did you manage to cope? And so for him, that was a really important thing, and that's why he trusted the young man who was his health caseworker. And actually, the young guy both of them were really into basketball, and that was a really big bonding thing, and they would go to and shoot some hoops, and then they'd have a talk about what was happening. And then sort of building on both the relationship and their knowledge of the context was the ability to sort of micro-adapt service deliverables. And so, Pura Whetū, for example, will have a contract to follow a young person who has maybe been suspended from school, and they say we'll be following up weekly with a mentoring program, but they would describe really well how they would adapt that for that young person. And so the sort of ability to do micro-adaptations, but also when we had an example from one of the women in India, she said, well, because I know that the woman next door is a really good sewer, I was wondering if you two would like to get together and you could go and have chai. She said she would be really happy to do some sewing with you. And so there, her understanding of who lives next door, how do you build community relationships, then, was a possibility to help the young woman who had been at home with a really strong social anxiety. And so kind of using your contextual knowledge, your relationships, being able to adapt things in a small way were really, really significant. So just sort of wrapping up some of the ideas, I think when people came up with the idea of task shifting, it was a kind of, how can we save money? It takes too long to train psychiatrists, and, they'll do a good enough job, but it's kind of seen as a stop, like a sort of putting some blue tack to stop a cup leaking or something. But what studies actually suggest is that it's a completely different kind of care that's actually really high quality and meeting the needs in ways that maybe a psychiatrist never would. And for some people, a non-regulated frontline health worker will lead to and support outcomes that they wouldn't have got with really hi-fi professionals. So the relational care is particularly characterized by caring rather than by outcomes and performance. Sometimes it's more relevant and appropriate, but it's not that we're pitting one against the other. We totally need psychologists and we totally need psychiatrists, and we also need, but I think we also can increasingly see there's value in local community workers. Some of the challenges, and I'm just wrapping up, some of the challenges are that in a lot of low-income settings, staff are sometimes, frontline workers are listening to some really, really difficult situations, and they haven't really got the safeguarding that we have in place for many professionals in New Zealand. And I know with the NGO in India, which I've had quite a bit to do with, they've explained that there's just actually no psychologists in that whole city of 300,000 people, and so they don't know how to get supervision, and we've been trying to set up remote supervision. Sometimes when you live in a community, it's really difficult to and you know a lot about someone, it's quite hard to manage that. And peer support, it's all there's lots to sort out, and it isn't all black and white, but it is working well in quite a few settings. So what do we get? I just thought I'd show myself dressed in a sari. What do we get when we use data from two countries? I think it was a little bit like Justin in his talk this morning, that there's times when we can learn from more extreme examples or different settings, but we also know that we can learn from low-income countries where they've had health workers for many years, and it's increasingly a feature in New Zealand. And that I think probably we recognise there is value and lots to be learnt from informal as well as professional approaches, particularly for disadvantaged communities. So just wrapping up, I'm really, really convinced that relationships are core, whether we're working in sports or counselling or health or anything else. And how do we know what a good relationship looks like is a quite important question for me. I think making things fit for that place is important. I'm not really big on the one-size-fits-all idea. And that when we provide healthcare and mental health care, it has to be engaging with some of those big structural determinants as well as engaging with the individual's problems. There are some awesome people writing about this, and if you're interested, I'm happy to share the references. And I just want to say thank you to the two funders who were part of these studies, and this was a study that we had published earlier this year, which was focusing on the work in India. So thanks very much.